10 minutes, I'm going to talk about risk stratification of mild traumatic brain injury. So traumatic brain injury is actually a big problem, and that we see about 6 million patients in emergency departments each year for chest pain, and we see about 5 million patients who are evaluated for traumatic brain injury. And out of that 5 million, about a half of them are diagnosed with traumatic brain injury, and about 70% of that number actually do fine. But the big problem is that there's this 30% that end up not doing too well. And we currently have no tools for trying to figure out who is going to do well and who is not going to do well. And as a practicing clinician, that's one of my biggest frustrations, because it's really important to figure out how to treat these patients, how to refer them to additional follow-up, and then also just the basic things like, should they go back to school? Should they go back to work? How long is long enough, to stay off mental exertion? And so these are all very important questions that need to be answered, and we basically have no tools for answering them. And so the bulk of my work is to use data-driven approaches, utilizing a bunch of novel technologies, including proteomics, genomics, metabolomics, and advanced imaging, and then use that in addition to existing patient data to come up with prognostic models for trying to figure out which traumatic brain injury patient is going to do well versus who is not going to do well. And as part of this, we've been involved in this prospective cohort that I call HeadSmart. HeadSmart is a prospective observational cohort that enrolls patients in two distinct emergency departments, two geographically distinct emergency departments. And we collect data based on the NINDS common data element for collecting data for TBI studies. And we get a bunch of blood samples, both serum and plasma, and mRNA and DNA samples at baseline and at a bunch of time points afterwards. And we also follow the patients up at 1 month, 3 months, and 6 months after injury. For some people, we talk to them over the phone. Others, we have them come in person, and we do a full battery of neurocognitive and psychiatric assessments. And one of the big questions that has been plaguing us is, what is TBI? Who has TBI? So the American Congress of Rehab Medicine has a criteria for who has TBI. And according to them, if you have some blunt head injury, you should also have evidence of physiologic disruption of brain function, like loss of consciousness, memory loss, altered mental status, and focal neurologic deficit. But for those of you who practice emergency medicine, you know that you've seen people with big old head lacerations who do not have loss of consciousness or memory loss or any of these other things listed. But there are chances that they actually have brain injury as well. And these are people who are underrepresented in current TBI studies. And through this cohort, we've even found out that they receive no discharge instructions at all about head injury, because we're not attuned to thinking about them in terms of having real significant brain injury. However, most of the time, these are patients who the American College of Emergency Physicians recommend should have head CT scans during their evaluations. And so we've coined the term hybrid for this group of patients who are head injured but don't necessarily meet the criteria for traumatic brain injury. And one of our first questions was, what is this risk in this group of hybrid patients? And so we're doing a study to determine the risk of adverse outcomes in what I call the hybrid group. And so within our HeadSmart cohort, we divided the TBI patients into 3 groups. There was the hybrid group, who are people with head injury but no evidence of brain injury based on the American College of Rehab Medicine's criteria. Then there are people who meet the criteria for TBI but have a negative CT scan. And then there are people who meet the criteria for TBI and have a positive CT scan. So those are 3 TBI groups. We have 2 control groups. We looked at patients with traumatic injury, like ankle sprains, fractures, and so on, who do not have any head injury, because we're pretty sure they did not hit their head and they did not have significant acceleration, deceleration forces during their trauma. We also looked at healthy controls. And there were 3 outcomes we were interested in. One was disability, we used the Glasgow Outcome Scale Extended, which is a scale used to measure functional disability post-traumatic brain injury. 8 means you're back to where you were before injury, and 1 is you're dead, and anything in between. And the rest of the numbers are somewhere in between. We also looked at post-concussive symptoms, and we also looked at depression. And I'm going to show you some of the initial results that we had. So we've looked at almost 300 patients so far, and the patients with head injury but who don't meet the criteria for traumatic brain injury are the ones in the green. And as you can see, their risk of disability, for example, is, keep on moving, their risk of disability is lower than those who are ACRM positive and CT negative, and even much lower than those who are in the red, who are ACRM positive and CT positive. However, their risk is still higher than the orthopedic injury controls, or the healthy controls. The ortho controls are the ones in yellow, and the healthy controls are the ones in black. So if you had some sort of head laceration, no loss of consciousness, no memory loss, no amnesia, at 1 month, your risk of incomplete recovery, meaning you're not back to what your functional state was before you had this injury, is still about a third. So about a third of these patients who we think are going to be okay end up not being okay. And this is a big problem. And when we looked at other outcomes like post-concussive symptoms, we saw almost the same thing. For depression, it was a little less, but the differences were still there, that these patients who we're calling hybrid patients still are at high risk for adverse outcomes. And so we sort of wanted to find out from the patients, what they thought about what their recovery trajectory was going to be. And so we asked them this simple question: what's your understanding of how well you're going to heal from the head injury? And we asked them this question right in the emergency department. I'm going to have to walk you through this table a bit. So the first group are people who talked to their physicians about their injury, and then based on discussing with their physicians, they thought they were going to be high risk. And then the second group are people who discussed it with their physicians, and based on that discussion, thought they were going to be low risk. And then the rest are people who did not discuss with their physicians, and the first group thought they were going to be high risk, the second group thought they were going to be low risk, and then the last group just had no idea. And accuracy we are defining based on what actually happened to them at 3 months. So if you said you are high risk, you're accurate if you actually end up still having persistent symptoms at 3 months. And if you said you're going to be low risk, you're going to be accurate if you were fine. And basically, it's a coin toss. Basically, patients don't know. Those who think they're not going to be fine, half of the time they were fine, half of the time they were not fine. The interesting thing is that those who did not discuss this with their clinicians but thought they were high risk, 100% of the time, they didn't do well, which could be a self-fulfilling prophecy maybe, that they just thought that they were not going to do well, and so they continue to play the sick role. And I do understand that with outcomes from traumatic brain injury, it's more than just the injury itself. It also depends on everything else that's going on in your life, and we're putting all that stuff together in models. So patients don't know. What about clinicians? How good are they? So we looked at sort of clinician gestalt for trying to figure out who is going to do well versus who is not going to do well. And this is the question we asked them, that do you think, based on everything you know, this patient is going to be back to their pre-TBI functional state after 3 months? And then we asked them a second question: do you think they're going to have post-concussive symptoms, which are headaches, fatigue, insomnia, and so on, 3 months after the injury? And again, it was like a coin toss. So when the physician said yes, the patient is going to be fine, they were correct 53% of the time. And when they said no, patient is not going to be fine, they were correct 40% of the time. So clinicians don't know, patients don't know. So we really need novel tools. We need novel ways for trying to figure out in an objective way which TBI patients are at risk for bad outcomes versus who is not at risk for bad outcomes. And that's where some of the stuff we're doing comes in. And recently we reported on this protein called brain-derived neurotrophic factor. Now, this is a protein that is released in the bloodstream based on neuronal activity, and it's usually higher when you have high levels of neuronal activity. And it's very important for neuronal survival and for differentiation and for migration and branching of neurons. And so what we did was measure BDNF in a couple of different cohorts. We looked at BDNF in people who were fine, healthy controls, and also in 3 different cohorts of traumatic brain injury patients. And what we noticed across all the groups was that BDNF levels were really low amongst the traumatic brain injury groups. Those are the first 3, or the second 3 in the graph, compared to the healthy controls. And at SAEM, we're also going to present our finding that amongst traumatic brain injury patients, those with positive CT scans had much lower BDNF values than those with negative CT scans. And the other interesting thing we found was that when we divided people into 2 groups, low BDNF versus high BDNF amongst the traumatic brain injury patients. Those with very low BDNF, their risk of having bad outcomes at 6 months after injury was almost 90%, compared to, a still high rate, but more in the lower 70% range for those who had normal BDNF. And this is BDNF values that were obtained on the day of injury. So based on what we know on the day of injury, we can tell you what's going to happen 6 months down the line. And this is just one biomarker. We do know that the outcomes, like I said before, or the predictors of the outcome involve a whole lot more than just one marker. And so part of our ongoing work is to, measure a bunch of other markers. We're actually looking at high sensitivity troponins as well, which I think it's really interesting because we've known for a long time that troponins are elevated in neurologic injuries. But I think they're going to have an important prognostic role within this multi-marker panel that we're developing. We are also looking at the importance of catecholamine surge in traumatic brain injury because it has a direct association with cerebrovascular reactivity. Additionally, thanks to the Injury Center, we've gotten some preliminary, some grant funding to do metabolomics work, and so we're going to be looking at the metabolome of good recovery versus bad recovery. Again, our whole goal is to see who is going to do well, who is not going to do well. How can we figure that out very early so we can institute some measures to change their trajectory? And basically, that's what I just said, that we will use all this information to develop prognostic models using machine learning tools, again, to figure out how to separate good recovery from poor recovery. And that's what I have. I thank a lot of people who've been able to help me along this journey. Any questions?
Fred, thank you for talking. For folks who may not know you as well, can you just talk a little bit about, so your foundational training, you have a training in emergency medicine, and then you went on to do a PhD
in clinical investigation. So
with work
after residency, I was a simulation guy. I went to Hopkins as the director of simulation education for our residents, and I did that for 2 years. Won Teacher of the Year award. Did pretty well with teaching, but decided to do research, and so I took time off to go back to school and get a PhD in clinical investigation. Did a lot of work with high sensitivity troponin. It's probably one of the things I know a whole lot about. And then along the line, we was working in the lab. We discovered a bunch of markers that were very useful for traumatic brain injury, and since then have been working to develop that further.
So Fred, that was a great presentation. I appreciated hearing that. A couple questions. One is, there was that one group with the orthopedic injuries who had that 18% incidence of post-concussive syndrome, which is just strange, especially when you look at what the list of post-concussive symptoms are. And I guess the other question would be, is there any, it sounds like from, are there any high-risk attributes to some of these patients of phenotype besides biomarkers that one can look at in terms of a clinical evaluation short of biomarkers? which seem to have any kind of sensitivity or specificity?
Yeah, so about a year ago, we presented that work at the National Neurotrauma Society meeting where, using this cohort, we looked at just clinical variables, and age was important. Unfortunately, race was important as well, but I think there are other things that cause race to be important, and it may be more of socioeconomics than race itself. And so we're still working to tease that out. Education level becomes very important, and there's one interesting variable we've been collecting, which is breadwinner status, and that turns out to be important as well because if you're the breadwinner and you've got to like get up and go, even if you have a bunch of symptoms, most of the time you tend to compensate and still push through, and so are less likely to report some of these symptoms. Um, and another proof of that is that amongst the people who didn't discuss their prognosis with their clinicians and thought they were high risk, they really ended up being high risk. So some of this I think is also sort of your mental state and whether you think you're going to do okay or not.
Probably a pie in the sky question, but how do you think this may impact? First of all, I'm sure we haven't done this on little kids, but we have such a concussion industrial complex in this country around youth sports. I would love to hear your views about how these studies may impact better youth sports or anybody's mild traumatic brain injury, because I think we've done so many crazy things to try to manage concussion or mild traumatic brain injury, especially in developing brains. We don't even know what the right answers are. We have some, but we don't know. I'd love to hear your views on that.
So I think it's still really early, and the evidence is unfolding. I think much as I studied this, there's a whole lot of hype about it, and not all of the hype is important. That there is at this point some amount of overdiagnosis, and that there are lots of benefits to youth sports, and the very significant injuries. We have to figure out how to make games safer and how to avoid them, but I think we also have to make sure that we're not swinging the pendulum so far that we're making people afraid of participating in things that are actually beneficial for them.
Great. I think we'll end there, and I'll just end with the thought that a field that's that open with your background is a beautiful a crossover for early career development growth. So